Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today, my topic of discussion is about microbial keratitis. This is an anterior segment photograph of a patient who is suffering from microbial keratitis. We can see deep ciliary congestion, red inflamed eye, and there is a central large corneal abscess occupying the central visual axis, and along with that there is inferiorly hypopion, the pus collection which has formed hypopion. This is the second photograph. Here we can see that the corneal abscess is settling down and the hypopion has gone, but ciliary congestion is still there present. So this is another photograph after the treatment of the patient in which signs of improvement are there. So whenever a patient comes to us with such situation, usually their presenting features are decreased vision, congested, inflamed eye, and severe pain, and along with this the eyelids may be swollen, inflamed. So we start our examination with the visual acuity. Along with visual acuity, we go for the anterior segment examination. We see the ulcer, its location, size, shape, its depth. Along with that, associated stromal infiltrates or corneal abscess, anterior chamber activity. Is there any hypopion pus in an anterior chamber? Basically, these are the things we do over there for the anterior segment examination. And we also notice that the corneal ulcer is size and its location from the limbus. Is it central, mid-periphery, or in the periphery? These are very important things which play a crucial role in their management. After that, we try to see the fundus. Very important to see whether the vitreous is involved or not involved. The reason is if vitreous gets involved, the things are going towards endophthalmitis. If we cannot see vitreous retina, then we go for the B scan to rule out vitreous activity. Intraocular pressure can be checked. If applanation is not possible with tonopens, it can be seen, and usually it is raised because the eye is inflamed, congested. So these are the basic things we usually do for the examination in a patient with microbial keratitis. And all these things are documented. And preferably, if the facilities are available, digital photographs of the patients are taken, which are very important for monitoring our treatment. And if digital cameras are not taken, there is a scientific way to draw the diagrams, corneal ulcer, location, size, shape, abscess, in the scientific way, and the presence of infiltrates, hypopion, its height, all these things can even be drawn in the conventional way if digital cameras, slit-net mounted cameras are not available. So after this anterior and posterior segment examination, and we have ruled out endophthalmitis, all these things, it is very important to go for staining and cultures. This is very important, and we usually should go for gram staining and Giemsa staining. And in this slide, I will show you the two slides are prepared. They are properly marked and they are put into the container for the slides. Gram staining is done to rule out usually gram-positive or negative bacteria, while Giemsa we do it for bacteria, fungi, acanthamoeba, and even some parasites. So these things can be done. So once we have started this culture, taking specimens, usually these are done with the Kimura spatula. If not available, even 15 number blade can be used, and a proper sample should be taken from the base and from the margins. And the slide is showing you the blood agar. Blood agar is basically used to for the culture of the aerobic and facultative anaerobic bacteria. Chocolate agar. This is used for the aerobic, anaerobic, Neisseria, Moraxella, and Haemophilus. This is a seborrheic dextrose medium. This is basically used for the culture of the fungi. This pink color culture media is McConkey. McConkey is basically used from the gram-negative bacteria culture in growth. And these are two culture media in the slant. In the tubes, you can see thioglycolate medium and seborrheic dextrose agar. Thioglycolate is basically used for the aerobic and anaerobic bacteria, while seborrheic dextrose, as earlier mentioned, for the fungal growth. Algae medium. Algae medium is basically used for the growth of the mycobacterium, also not a routine culture media. So as I mentioned, culture and sensitivity is very important. And we can go for this. Basically, I showed you different culture media, but I believe basically this blood agar, chocolate, seborrheics, thioglycolate, and McConkey. These five are usually sufficient. The culture media should be immediately sent to the microbiology laboratories, and if there is any delay, they should be kept all the slides into a refrigerator at 37 degrees Celsius. So now we come towards the different stages of corneal ulcer. The first stage of the corneal ulcer is called the stage of progressive infiltration. It is the stage when the host mechanism is working over there. The neutrophils, the polymorphonuclears, and the lymphocytes all are migrating along the epithelium, and even from the nearby stroma, they move towards over there to control the inflammation and infection. And just during this stage, sometimes if the host defense mechanisms are weak, there may be an element of damage to the tissue and necrosis in the cornea. That may happen. But this is basically dependent upon how strong are the host defense mechanisms. So this is the first stage we call the progressive infiltration phase. The second phase is the stage of active ulceration. During this stage, the necrosis and sloughing of the stroma and Bowman's membrane occurs. The walls of the ulcers swell up because they take up the water and swell up over there. So, and leukocytes infiltration occurs. So these are the two stages from the total 4 stages. The second one is active ulceration stage. So the third stage is stage of regression. Here what happens that there is a well-defined demarcation line is usually formed between normal and abnormal cornea, and the leukocytes and all the defense mechanism, humoral and cellular defense mechanisms come into action, and they kill these bacteria who are working over there. And initially the ulcer may grow in some size because they also digest the dead debris over there, but after that it starts healing. So this is basically the third stage of any corneal ulcer. Once the things are going in the right direction and it is healing, then over comes the last stage, and that is the cicatrization stage, where basically the ulcer heals and epithelialize, and you can see over there vascularization, all these things. So this is the fourth stage if everything is going fine and no perforation and nothing has happened. Well, this is a very interesting slide. This is a modified Jones severity grading system in which they have graded the corneal ulcer into 3 grades: mild, moderate, and severe. If it is less than 2 millimeter, mild, 2 to 5 moderate, and more than 5 millimeter is a severe corneal ulcer. Then they have also counted the depth. If it is involving less than 20% of the corneal stroma, it is 20 to 50%, or it is also involving the more than 50%. And then it has also added the infiltrates, whether these are superficial infiltrates or they are involving the mid stroma, or they have gone into the deep. The deep one are the severe. It means that they are involving the whole cornea. It means that the infection is not superficial, it is going deep down into the cornea. And the other thing is the scleral involvement. They have also involved in this grading system. That is, if in first and second the scleral involvement is not, but in fourth the sclera also gets involved. So this is a grading system which gives us an idea about the severity of the condition. And number two, it defines our plan of management. Usually we can say that in mild cases, we can go with broad spectrum antibiotics like quinolones, ofloxacin eye drops, ciprofloxacin eye drops. This can be our choice. Moxifloxacin is very good in mild cases. But if the things go towards the moderate to severe things over there, then we definitely go for the fortified antibiotic drops. We'll discuss in the later slides. Mentioned if there are small ulcers less than 3 millimeter in the periphery and they are not involving the visual axis, so monotherapy with moxifloxacin and quinolones, these can be applied over there, can be used. But if it is the bigger one, stromal ulcers over there, then we usually start the fortified eye drops. Two types of fortified eye drops to cover the broad spectrum, gram positive, gram negative, all the types of things to prevent the eyeball and also the eye vision. So there are different types of fortified eye drops which can be started. For example, we can use fortified cefazolin, fortified vancomycin, ceftazidime. They can be started. Any two of them proper covering gram positive and gram negative, and until our proper report comes. Usually report takes us 48 hours sometimes, and even 72 hours. But gram staining gives us an idea also about what to start over there. So along with this, we have to put the patient on cycloplegics. Very important. Cycloplegics, you can use cyclopentolate and you can use even atropine eye drops. Cycloplegics role is basically to break the spasm of the eye. Eye is inflamed, red, so break the spasm over there. It prevents the formation of the synecdoche and it stabilizes the blood aqueous barrier. So it has a very important role in the management. Apart from this, we can also put the patient on the lubricants. The lubricant eye drops are basically over there to provide an environment for the eye to epithelium to regrow. Number two, all the dead debris over there get washed up with these lubricant eye drops. Any lubricant good eye drops can be used, hydroxypropyl or carboxymethyl, whatever, they can be used to clean up there. Along with that, very important that during this infection, the eye is inflamed. All these, I showed you in the first slide, there is hypopyon, the pus is formed over there. These inflammatory cells go over there and clog up and the trabecular meshwork, the drainage of aqueous humor. So the IOP, intraocular pressure, is raised over there. So we can use anti-glaucoma medication. If tonopan we find out, or digitally we see the eye is inflamed, so we should use, and the beta blocker is a good choice, because once the pressure is decreased and those channels, trabecular meshwork are opened up, the drainage will be easy and pressure will be less. So these things. Well, if we talk about the systemic antibiotics, they don't have that much role in the management of the corneal ulcers unless and until the sclera is getting involved. Then we can think about these oral ciprofloxacin. That is a good choice which can be used. These were things I was discussing when everything is going in a good direction. But sometimes the infection is so severe, and or the patient comes to you so late that it is really very severe condition. There is rapid keratolysis process going on. There is death of the keratocytes occurring over there, and the stroma starts melting in spite of your full treatment. The ulcer process keeps on increasing, and even it can go up to involve the decimus membrane. It's a very strong membrane, and sometimes it bulges forward to make a desmatocele. But if it is sloughing off everything, you can encounter a corneal perforation. This is a very serious condition because now eye is exposed to the external atmosphere. So if it is small, sometimes the iris comes forward and plugs it off and seals it off, and it is closed over there by the iris. And you can later on, these are the conditions which later on lead to the formation of adherent leukoma, the corneal opacities. Well, if the corneal perforation is very small, we can use cyanoacrylate glue. We can put it over there, seal it off, small perforations, and then we can apply the bandage contact lens over there. Yes, and the patient can be put on the topical antibiotics, and he is followed up routinely. The anterior chamber is formed, and infection usually settles down with the passage of the treatment. But the the structure is saved. Other options are, if this is not, then AMT can be tried. And if other option is, sometimes conjunctival flaps are used, Gunderson flaps like this, to cover the area over there temporarily. So these things can be, but if it is more than 2 millimeter, then you have to think about the tectonic graft over there. You have to put a something patch over there, corneal graft, to control this. This is therapeutic tectonic keratoplasty. The advantage of therapeutic penetrating keratoplasty is that if we see that the infection is so severe, it is not settling down, this immediately removes the source of infection over there. And along with that corneal perforation and all these things are removed. Usually it is said in the 2 weeks literature time that we should wait for before going therapeutic penetrating keratoplasty, but it varies. It varies. If in front of your eyes things are getting worse over there, and you see that things are not going to improve and you're going to lose the eyeball, then you can adjust this. This is not a fixed time duration. You have to save. Your first priority is to save the eyeball, whatever maneuver you use. And once the eyeball, the structure is saved and infection has settled down, then later on, a quiet phase of at least 6 to 8 months, then therapeutic, the penetrating keratoplasty for vision restoration can be done. But the initial target of any physician is to control the infection and save the eyeball. Come towards a very controversial thing about the management of the steroids. Usually whenever there is infection is going on over there, all the inflammatory elements are working over there. Cytokines are released, collagenase, TGF, and all these things go over there and destroy the collagen and extracellular matrix over there. And death of keratocytes leads to the vision loss. Keratocytes are sometimes converted into the active fibroblast, collagen is laid down, extracellular matrix is laid down, and all these irregularly form a scar over there, which ultimately decrease the vision. So this is basic the pathogenesis I discussed. Now many people believe, who are in the favor of the using this steroids topical, they believe that because of using the topical steroids, number one, we decrease the congestion, inflammation, and the pain is relieved. And number two, that all these cytokines who are the main culprits and who are doing all damage over there, they are controlled over there. So they believe that it also decreases neutrophils, chemotaxis, so less inflammation. So they believe to use the topical steroids. While another group, which is against the use of the topical steroids, they believe that it is very risky to go at this stage because dexamethasone, for example, eye drops, they decrease migration of epithelium over there and inhibition of the neutrophils. So the host defense mechanisms who are trying to control the infection, they get weakened up, and it makes a negative effect in the eyeballs activity to control it. So they believe it is very risky to introduce the topical steroids. And much research has been done about this, about how to use, when to use. But I believe, my personal opinion is that in the case of active infection, when there is active infection, abscess over there, hypopyon, all these things, first target should be to control the infection and inflammation. And once the active infection and inflammation has been controlled over there, then at some stage, the physician can think of introducing the topical steroids. Yes, once the infection is controlled, he can introduce, but that has to be done under the umbrella and under the care coverage of the full antibiotics, topical antibiotics, aggressive. So, and these patients needs more frequent visits as compared to the normal, because at any stage, if we see that things are deteriorating or reversing back, these steroids can be stopped. Because the only reason the steroids are introduced, of course, to control the inflammation, the reason is they believe that it plays and helps in the controlling the scar formation. Because if scars are formed over there, and they can compromise vision. So my opinion is that during active and acute infection, these topical steroids should not be used, and we should wait until the things get under control. We will see the hypopyon is settling down, the abscess is shrinking over there, corneal ulcer is healing, the stromal infiltrates have started fading out, and congestion has decreased. At that stage, it will be much better to go under the cover of the topical antibiotics. So, respected audience, this was a topic I wanted to discuss, very basic topic, but very important topic, routinely encountered in eye emergencies, its management, its basics, its pathogenesis, different stages. I hope this presentation will be beneficial for our respected audience. I want to thank once again all of you for your attendance and attention. Thank you.